So what is happening when we manipulate the spine? We're going to look a little bit at tissue behavior, how tissue behaves under our hands. I think it's really important when we touch a patient and we impose a force upon a patient, we understand what the consequences are. Before we prescribe a medication, we look at the chemical reaction, right, of that medication. We don't just say, hey, we gave the medication, they felt better today, right? There's a standard that we don't necessarily hold ourselves to as physical therapists that I think it's important to. But before going there, I just want to spend 1 second and I was many years ago MTC trained through Stanley Paris and University of St. Augustine, but before that I practiced very much in the kind of a Michigan State model. For some of you are familiar with osteopathy, and both of my mentors in that regard, one was Jeff Ellis, who had been with the IPA and worked with Michigan State, and the other, sadly, Mark Bookout, was a mentor to me who I recently went to refer a patient to him in Minnesota and found out he had just died of cancer at a young age. So just take a moment to recognize my mentors who helped me along the way, who both had sad unfortunate endings. So what's the objective? Enhance awareness of mechanisms at play during lumbar spine manipulation. So yes, we're pushing on the vertebra, what's happening, or we're twisting the vertebra, or pulling on the leg. Synthesis, I would hope that you would integrate this new understanding to optimize individualized approach to spinal manipulation, as opposed to a blanket approach. And then from an implementation, incorporate whatever knowledge might be useful to you into a clinical application towards spinal manipulation. Spinal manipulation is nothing new. And I apologize to my former students in the room. You've seen some of these slides before, although they're updated, right? It's been around a long time. And this is from Apollonius in the 2nd century BCE, who shows walking on backs. And this is actually from Hippocrates, applying tension across the system while walking on backs. This is from Galen in the 2nd century after BCE, right? And it's not unfamiliar to a Maitland mobilization. You might see they're slightly side bent left, right? And they're stretched out. And it looks to me like he's doing a PA mob on the right transverse process to produce left rotation and side bending, right? And so I always, and we really have this very much right now. I mean, I've been doing this for quite a while, and I spent many years teaching. And every couple of years, I find I'm disabusing students of the newest and coolest, right? And I even went down to do a lecture at Cornell for the PM&R residents recently. And I was talking about the biomechanics of closed chain, which are familiar. We know biomechanics, right? It's a real science, and we can reduce some of it to math and this and that. And then and the chief resident at some point looked up at me when I said, look, it's okay to train where the knees extend in front of the foot. If you have a patent ACL, every time you step down a curb, right? Every time you get out of bed, your knee extends in front of your foot. That's okay for a squat. And she looked at me very excited and said, do you know about knees over toes? And I said, no. And maybe some of you do, but I'm sure it's a craze on social media that I'm not aware of that basically restates a lot of known knowledge and is making someone a few dollars. On the other hand, this one you don't see much, and that is using the board by Hippocrates, and this is from a Persian text. So there's really nothing so new here, right? And then, although in the Middle Ages or medieval time, of course, they improved upon it by making it look like a torture mechanism using a Hippocratic scamnum. But all of this, and you should see the stuff for the Schroth therapists that are out here, you should see the stuff they did for Hippocrates, they did for scoliosis. I don't know if you've seen it, the ladder and so forth. There is an interesting, it's total digression. But at one point, you read so much about this that I got a version, not in Greek, in English, of Hippocrates' actual text and looked through it a little bit. And he mentions about the Hippocratic ladder, right, where you drop the body and you try and straighten a scoliosis. So it's two nude men are standing on either side and you're on a pulley and they suddenly drop it. Right. And the idea is you reduce the scoliosis. In his book, he's often been cited as proposing this. In his book, he actually says that this is a procedure that's often done by basically ambulance chasers. Somebody builds a thing in the middle of town, invites everybody, and performs this technique, and he doesn't really think it's effective. So although it's been attributed to him, it is kind of interesting. And by the way, for upper thoracic scoliosis, they actually would contain the neck and put it in a hood. And those are available in the Columbia Library. Not the machines, but the images. This goes back to the 1800s. It's out of Sweden, and it's gymnastics. And it's a really interesting, right, look here, because these are images that were put up by Anders Ottesen, but they go back to a guy named Kellgren, who is the father-in-law of Cyriax's father. So there's Edgar and there's Cyriax. It goes back to kind of the orthopedist who brought orthopedics to PTs, right? And this is from Kellgren, who was Swedish, and his father-in-law. So what is that manipulation? Enough with kidding around. The APTA has been really clear, you know, in my career and some of yours, right? There's been a real battle over whether physical therapists should do manipulation or not manipulation. So the APTA has gone back to 1925 to show the history of manipulation as part of physical therapy, and Mary McMillan statements and so forth, where there have been many challenges whether we're trained to or not. And I think some of those challenges are fair, but as part of such, there's been, you know, APTA has put out all this information, and one of it is thrust manipulation, specific diagnoses, right? That it can also hold up legally as well as kind of describe what we do. And there really is not a distinction between a mobilization and manipulation, right? As much as there is its speed, its velocity, right? It's the oscillation or not oscillation, but they define both as a non-thrust and a thrust manipulation. Just a quick look. This is a nice review of manipulation for the lumbar spine and looking at pain. It's a comparator of a group of studies, right? Looking at the efficacy or the effectiveness of manipulation. You can see on pain for acute patients with acute low back pain, right? The effect size is small, it's short-term outcomes, but if you look at it, everything to the left of the y-axis there is a favorable outcome relative to the comparison, right? The comparative. And then they looked at function and looked at the studies, and they were randomized controlled trials, right? So they were high quality studies as we view them, as we classify them, and they looked at function. And again, for the most part, right, they found that manipulation is effective in terms of functional gains, short term for acute low back pain. To that end, this is old, this is from a paper in 2009, National Center for Health Statistics, but I haven't seen more recent statistics. As of 2007, more than 18 million US adults received manual therapy in 1 year for a cost of $3.9 billion. I'm sure that's higher now, in both more Americans and more money. And I always say, in many years in medicine, you know, if there's a trowel, there will be people feeding at the trowel, right? And so if there's a lot of money in this, there's a lot of interest in who does it, who doesn't do it, and so forth, unfortunately. Low back pain was the most common reason for seeking manipulation. And from the AT-PTA perspective, benefits outweigh the risks, right? Assuming, and I think this is important, thorough examination and an evidence-based impairment-based approach is taken. You screen for red flags, you attend to contraindications, right? And you modify techniques when appropriate. I thought this might be a nice way to look a little bit at the mechanisms here. What you see here, and this is based on a Stanley Paris model, what you see here is you see a midline neutral for the joint, right? The end of motion there, you see the neutral, then you look all the way to the left, you see the passive motion available, and the joint play at the end. If you look to the right, there's a pathology to the right, or there's a lack of mobility to the right. So what we see here is that the active motion is much smaller than to the left. The pathology is here to the right. So what do you encounter in abnormal end feel, right? So where is your thrust, right? So there's this midline neutral. You have a new neutral, don't you? A pathologic neutral, almost as if the ball in the bowl has moved to one side of the bowl, right? Because often you find a different neutral position once somebody has a limitation in one direction, right? So where would we do the manipulation? At the pathologic restriction, right? So not necessarily manipulating a normal tissue. If we're manipulating for the effect of, if we're doing a thrust manipulation to increase mobility, then we're typically not doing it on a normal joint. We're doing it on a joint that we perceive, at least, it may be a normal joint, but we perceive it as being hypomobile in some regard. There are other reasons to do a manipulation, but thrust in general is done to that end. Let's look at oscillations first. This is from a study done by Lee and Latimer, and they were trying to kind of calculate what's the force we actually apply. Again, if we're going to prescribe a medicine, what's the appropriate dose, right? What's the appropriate, how many times per day? How much do we give? Why do we give medicine A versus medicine B? I think the same is true with manipulation. Why do we do manipulation A? Because we, learned it on Sunday in a course, and today's Monday, we figured, what the heck, let's try it, right? And it's not that I've never done that, but I think it's better to have a better rationale if we're going to be taken seriously in this regard, right? So what you see here that's kind of typical of these manipulations, if you look, seconds are on the x-axis and forces and newtons are on the y-axis. And what you see is this oscillation in that kind of 120 to 240 newtons. And it looks like at about 3 or 4 per second. And that's probably equivalent to a grade 3 oscillation, right? Kind of a larger oscillation from mid-range to end range in Maitland terminology. So what happens when you do this, right? Have you thought about that? What's the point of cyclic mobilization or cyclic manipulation? Well, if you look at stress, which is the amount of force we're imparting into the system on the y-axis, and strain on the x-axis, notice how as you're working here, right, there's a constant amount of stress at the top, right? The maximal stress, you keep on reaching the same maximal stress as in this, pretty much as in this diagram. It's not perfect, but notice how the deformation is not. So the height is basically constant in terms of the peak, but what are you seeing? You're seeing progressive deformation of the tissue. That's what strain is, right? It's kind of like this idea, I'm taking a hanger and I'm bending it back and forth and back and forth. What's happening? Over time, it becomes hot, right? That's hysteresis. You let off heat and it becomes hot. Over time, the same force causes a greater bend and it'll break, right? You didn't increase the force. It was a cyclic loading, the same way bridges collapse, right? Under cyclic loading, people have probably seen that on YouTube, right? If they're not built correctly and they go through cyclic loading. So there's a reason to use an oscillation, right? The question is, what's your goal? If your goal is to get progressive tissue deformation, an oscillation might be a great way to go. We'll look at it in a little bit more detail. This is also looking at the effect of what's happening when you're loading and unloading. And if you see the blue lines I put in there across, right? What you notice is that when you're loading, right, and you reach the, let's say this halfway mark here, right? Look, you're loading here and you drop a line down and that's how much strain you've had. Strain is tissue deformation. That same unloading phase, look at where you are in terms of strain. There's a different amount of tissue deformation. So as you're thinking about it, understanding the mechanisms and the viscoelastic properties of the tissues you're manipulating allows you to target your manipulation in such a way to get whatever your goal is, right? Rather than just saying, hey, I learned to do this. I should do this for A and this for B. Why don't we reason through it and treat it as a science, that there is some science behind it. There's some art too, but there's some science. Right, so this is just a kind of, oops, that's not. This is a manipulation you probably well, very familiar with. The left rotation, mobilization, and joint manipulation. Right, we could do it as a low velocity. We could do it as a high velocity motion where you drop your weight. So, and excuse the background, this was during the COVID era. I was doing this for the students in our advanced orthopedics class, and actually I have a version of doing neuromobilizations where I'm in shorts and socks. I didn't even think of that. It was like such a different mindset during COVID, and this is my partner's daughter. So we were part of the same community. That's a long lever manipulation, right? Because you're crossing different joints to arrive at the manipulation point, trying to localize the force as much as possible. A short lever manipulation, right? Creating a skin lock on either side of the spine and the thoracic spine, right? And then a high velocity, low amplitude thrust, right? And so there's nothing so special about it. It takes practice, right? Like any kind of kinesthetic sense, like hitting a ball or dancing or playing a piano. But with practice, it becomes more and more natural. So Cornelia Kulig out at USC with Chris Powers looked at a study of, well, what's happening under our hands, right, as we do the manipulation. And I don't know if you people you've seen this JOSPT. It's an old study now, and it's just a force on the L3. You can see the hand here, right, over the L3 vertebra. It's an MRI, and they applied a force to see how much motion occurred at the different joints. So if the greatest motion was occurring at L3, L4, it also affected surrounding vertebra, right? So what are we manipulating?